Welcome to a webinar of posterior rotatory instability, not posterior, but rotatory instabilities of the knee. This is a corner of the knee, which is probably, these injuries are less understood. We talk about posterolateral, posteromedial, anteromedial, and anterolateral instabilities, and also about combined instabilities of the knee joint. We are lucky that we have Professor Volker Musahl. Professor Volker comes from Pittsburgh, University of Pittsburgh, where he has done extensive work in translational science. And I think it would be a treat for all of us to hear his viewpoint about the rotatory instabilities of the knee. Where are we today? Dr. Shreyash Gajjar will briefly introduce Professor Volker, and then we'll follow by a presentation. Shreyash, please.
Hello, everyone, and welcome to this webinar on rotatory instability of the knee. Where are we today? Although the concept of rotatory instability was introduced way back in 1970 by the French surgeon Dr. Paul Sigon, the less favorable outcomes of intra-articular surgical techniques, especially in certain patient groups in the last 2 decades, has led us to revisit the anatomy and biomechanics of the knee joint to recognize the importance and the role of the extra-articular structures in contributing to rotatory stability of the knee. And we all know that over the years, the Pittsburgh knee unit has been well recognized for their contribution to knee surgery. And today we have a renowned member of that team, Professor Volker Musahl, and we welcome him. He's a specialist in the management of injuries to the knee, shoulder, and elbow. He's the Blue Cross of Western Pennsylvania Chair in Orthopedic Surgery, Chief Division of Sports Medicine, Medical Director, UPMC Rooney Sports Complex, Program Director, Sports Medicine Fellowship Program. He completed his MD from Albert Ludwigs Universität Freiburg in Freiburg, Germany, and subsequently his residency in the University of Pittsburgh Medical School, Philadelphia. Following that, he pursued a fellowship at the Hospital of Special Surgery in New York, and he returned to Pittsburgh in 2009 as an assistant professor and was subsequently promoted to associate professor and professor over the years. He's board certified by the American Board of Orthopedic Surgery with subspecialty certification in orthopedic sports medicine. He's also a co-director of the Orthopedic Robotics Laboratory, and his research interests include bioengineering research of the knee and the shoulder. He's assistant editor-in-chief of the ESCA Journal. He's part of the ISACOS Board of Directors, members at large. He's also the ISACOS Program Committee Chairman for 2019 to 2021. And he has several publications to his credit and is a faculty at various international and national meetings. He has also been recognized by Best Doctors Inc. on 2016 Best Doctors list in Pittsburgh Magazine. He is the co-head team physician for the University of Pittsburgh Varsity football team and also serves as a team physician for US Soccer Under-14 Boys National Team and Mount Lebanon High School. So really, the Indian Arthroscopy Society is honored to have somebody of your stature, Professor Volker Musahl, and we welcome you and invite you to please give your talk on rotatory instability of the knee. Where are we today? Please share your screen. Thank you.
There you go. Okay. All right. Can you see my screen?
Yes, perfect. Thank you.
Okay. Well, thank you so much for having me and for this nice introduction. I'm very appreciative. And thanks, Dr. Gajjar and Dr. Oberoi for inviting me. It's a big honor. I was in India a few years ago, I think 2017 at the Pune course, which I really enjoyed. So I'll share with you a few of my slides on rotatory instability of the knee, sort of my hobby for the last maybe 10 years or so. So again, thank you so much for the invitation. These are my disclosures. I don't really think they're particularly relevant, but I will show you the disclosures. I'm a consultant. I have educational disclosures and otherwise, as you mentioned, the journal, and we have several NIH supported studies, and I will show some of those share with you later in this talk. So So I'd like to start this with a case presentation. I think this is a very typical case, 21-year-old football, soccer player, twisting injury, and you can see the knee is quite unstable here under anesthesia. Pretty big Lachman, anterior drawer, and then here's the pivot shift. And not the biggest pivot shift, but we would call it at least a grade 2 pivot shift. But I'm going to talk exactly about what that means in a little bit. So the question with this case is, what are you going to do? You can see on the MRI, the ACL is torn, but nothing else is torn. There's no collateral injury, no anterolateral, posterolateral, medial, any other injuries, yet you have high-grade instability. So let me guide you a little bit through this. So rotatory instability is not a new concept by any means. You mentioned Paul Segant. I think he's one of the first ones that's been credited with researching this, and that little fracture you can see there by the asterisk on the lateral tibia plateau is the capsule that pulls off the lateral tibia when the ACL tears. So this is something we see probably in 1 to 5 out of 100 x-rays. Let me see, there you go. So I want to start with talking about anteromedial instability, which is obviously just as important as anterolateral instability, but not so much talked about. On these images, you can see two very typical injuries. On the upper MRI, you can see what we would call a ramp lesion, so a posterior medial meniscus tear. You see the little bone bruise underneath, and then the separation between the capsule and the meniscus. It's called a ramp lesion, and according to many, this will occur in almost 30% of your ACL injuries. So you got to look for this by putting the scope posterior. And then on the lower image, where the arrow is, you can see a root tear. That medial root tear doesn't occur all that much in ACL injuries, but it would obviously denote that there's some posterior instability. And then on the medial side, you have obviously the superficial and deep MCL, the posterior capsule, you have the medial meniscus, the posterior oblique ligament, and semimembranosus. The stress view on the right is something I will perform on every knee in the operating room where I suspect that there's more than just one ligament injured. It's very helpful, and Rob LaPrade gave some good data there, what to look for. For treatment, grade 1 injuries, obviously on the medial side, get treated non-op, and grade 3 most of the time get fixed. The big question is, what do you do with the grade 2 injuries? And they're these quote unquote bad grade 2 injuries where the meniscus is floating and where you don't have a complete avulsion, yet the instability is quite large and you should probably do some repair. I choose a direct repair as seen on these images over a reconstruction with a graft. Now on the lateral side, the story is slightly different. Here you can see the dial test in this patient on the left side is positive at 30 degrees. If it's also positive at 90 degrees, you're looking at the PCL, so not the topic of this talk. And then on the MRI there, you can see some injury to the LCL, the biceps tendon, and the pop-fib ligament. Those are the main structures. In addition, the popliteus that make up the posterolateral corner. Again, the stress fluoroscopy is really helpful. And you can also do the reverse pivot shift test as well as the dial test. For repair on the lateral side, again, the grade 1 and 2s, we will usually treat non-operatively, just fix the ACL and let the collateral structure heal. For the higher grade ones, I prefer a direct repair, but almost always I will aid this repair with a reconstruction. So here what's shown is a fibula-based reconstruction using an allograft semitendinosus tendon. In this country here, as mentioned earlier, I grew up in Germany. Allografts are not very available at all. Here in the US, allografts are widely available, and so we use them quite a bit. We can discuss this later if you wish. So now let's talk about antilateral instability. I think that's what many of you would like to hear about. And I also want to preface this by saying antilateral instability is not new at all. Obviously, Paul Segant described it before 1900 even. But since 2013, there's been an explosion of literature on this. I believe there are more than 600 articles written on that particular topic since 2013 in just 7 years. So that's really a phenomenon. And a lot of it is, to use an American hot topic, it's fake news. I hope you know what I mean by that. So, so antilateral instability. So first of all, there is controversy what the antilateral side is made up of. But really importantly, that's all I really want you to take away from this talk. It's the IT band, right? Then there's something people call the antilateral ligament, which has also been named the mid-third capsular ligament and many other names. And there's also the capsule itself. And then all of it together we call the antilateral complex. So the controversy really is what role does each structure play? And very important is that the restraint to internal rotation really is the ACL and then the IT band. There are disagreements on what exactly the ALL is. And I'm going to show you some images here. These images on the right are from Elmar Herbst. He was our fellow in 2017. He published a really nice pictorial essay in the KSSTA journal. Now, another question is, how many % of your ACL injuries will also have an antilateral injury? According to this study from Rome, almost every ACL has an anterolateral injury, and they described it in 4 different grades based on the hemorrhage that they see on this image here. Our experience is very different. We see maybe 5% anterolateral injury. Here's some images that I picked. This one on the right is from Dr. Fu, and the one on the left is from Camilo Hilito, looking at what happens developmentally. So these are fetal specimens, and on the left you can see the LCL is depicted there, and then with the asterisk that will be the ALL. I'm not so sure about that dissection, and if you look at the picture on the right, that specimen is about the same age. I think it's a little more clear really what happens. So you can see the biceps tendon, which develops very early, and you can see the FCL or LCL that is pulled away from the femur by the fibula, developing later stages of the development. So the fibula pulls the LCL away from the femur. Now on the anterior side of this, there is no such thing as a fibula or anything that will pull a structure away. So you can see clearly that there's no particular ligament, ALL or anything in the capsule, because developmentally it even doesn't make any sense that there would be such a thing. We looked at this a little bit deeper too. This is a collaboration we have with Kevin Shea, who's at Stanford. And we dissected here multiple relatively adolescent specimens. And we took the antilateral structures, so the capsule, IT band, everything together. And then we did immune histochemistry on this and looked at scleraxis and tenomodulin, which are transcription factors for tendon and ligament development. You can see on this graph, we really didn't find anything to speak of in that antilateral structure. So again, to make this point, there is no ligament or tendon in the anterolateral side of the knee. Obviously, this picture on the left is how this all started with the Stephen Clay's dissections. And I think the dissection is unclear because you're left with a picture that you're asking yourself, how did you get there? How did you get to a point where 2 such ligaments appear? And therefore, we did this study there on the right where we just do a more clear description of, after we cut the skin, how do we get to the anterolateral side? So you can see here the IT band is reflected. You can see the patella tendon, capsule, and then with the asterisks in the back there, the capsuloosseous layer of the IT band. So here's sort of a step-by-step description of this. And you can see the IT band has some deep fibers in the capsuloosseous layer, which some people may talk about as being the ALL. As you go further down, you see those deep fibers, And then if you keep dissecting out, then if you want to, on the very right, you can end up with a picture that looks like the one published in the Journal of Anatomy, where you carve out that structure. But again, I don't think that's a true ligament. Let me show you and let me share with you some of our biomechanics studies. So the image, the video that you see there is a robot that was developed. I'm going to go back one and let it run again. Femur and tibia is up top. Was developed by Hiro Fujie in Japan for knee kinematic movement. So on this video, you can see the knee flexing from extension to flexion. At the same time, what you don't see, but what you should know is a simulated pivot shift was being applied with internal rotation and valgus loading at the same time continuously. And so the graph on the left, you can see the green line is the ACL. So you have flexion angle of the knee on the x-axis and then the force carried by the structure on the y-axis. And we all know that the ACL carries most of the force near extension. And you can then see the antilateral capsule also carries some force, but starting more near 60 degrees of flexion and higher flexion angles. And keep in mind, the pivot shift happens around 25 to 35 degrees. The LCL does some load sharing with the antilateral capsule. And then when you cut out the so-called ALL, you will see that it carries a really negligible force. So I think it's a very powerful study. It won a Young Investigator Award at the OIS and is published in JOR. In the same study, we also did this, which is published in AJSM. We put strain markers onto the capsule. So the second image there shows the knee, and this is the anterolateral side. And then each of those little black dots are strain markers that we video throughout this simulated pivot shift. And then the rainbow map you can see next to it has the orange bar right through it, which is the proposed ALL. But then all these little arrows show where the strains actually went. And they went on average 40 degrees away from that proposed ligament. And if you kind of look at the map, you would say it's all over the place. Hence, we don't call it a true ligament, but a sheet of fibrous tissue. Now, this here is a more clinical study. It's retrospective, and it's been misinterpreted many times. I can see it when I go to ISACOS and AOSSM. People talk about it. But let me debunk it for you. So what we did here is we looked at 42 patients that had an ACL injury. We gave the MRIs to our radiologist and said, can you please grade the antilateral structures, just like you would grade the MCL, 1 being a sprain, 2 being a partial tear, 3 being a complete tear. You can see here what they did. They had 5% had like an actual tear, the rest only had some sprains. Then what we also did is, and I tell you this a little bit later, exactly how these yellow markers work, but we basically measure the pivot shift quantitatively. And then we could attach a high-grade pivot shift with the image and see what is correlated. And on the right side, you can see that both a medial meniscus tear and or lateral meniscus tear and or anterolateral capsule sprain signal will correlate with a high pivot shift. And I think that's very interesting, but of course there's overlap between those structures. And then MCL and posterolateral corner rather correlates with a lower grade pivot shift. So I think this is an interesting study. We also looked at, with Ken Onishi, who is a physical medicine and rehab specialist and a wizard with ultrasound, what in ultrasound the anterolateral structures look like. You can see like a grade 2 or 3 injury happens in very few of our patients, and we've done hundreds in the meantime. So anything much, much less than 90%, which was described in the Italian paper. Here's a very interesting study that I was involved with by Charlie Brown, who you probably know out of Abu Dhabi, and Al Getgood from Canada. They had a consensus meeting with us. I think it was in 2018, and we all went to London, England, about 25 people, and we discussed, you know, what is the anterolateral ligament. And we all dissected out specimens in front of us and explained our thinking and videoed it. And you can see all of that on the KSSTA website and in the paper that is cited on the bottom. And what we discussed is we put out a number of statements and disagreed on most of them. But what we agreed with is that the primary soft tissue stabilizer of coupled anterior translation and interrotation is the ACL, and secondarily the IT band, the lateral meniscus, and then far down the line, the ALL and anterolateral capsule. And we also said that the ALL, so-called, is an anisymmetric structure, meaning it changes its strain throughout the range of motion. Now, if you perform a lateral tenodesis, lateral plasty, extra-articular procedure, ALL reconstruction, all synonyms for the same thing, there is a potential to over-tighten the normal motion of the lateral knee. And the causes would be if you fix the graft with the tibia and external rotation, or you simply over-tighten the graft when you fix it. So we mentioned that in our article, and I want to be careful with this. There's currently no evidence that the modern LET or lateral tenodesis would lead to an accelerated OA, which has been shown in the 70s quite a bit. So here, the statements that we adopted, we talked about indications for lateral tenodesis. People would always ask me, and I'm sure you ask me at the end of this talk, what are your indications for it? So here's what we wrote, in some revision cases, and maybe some patients with high-grade pivot shift, with generalized ligamentous laxity, and then also people mentioned young patients with pivoting activities. So let me change gears here for a second and talk about the pivot shift and what I believe the pivot shift is. So if you take the knee, and this is basically adopted a little bit from Andrew Amos's work back in the late 90s, the pivot point of the knee is really not in the geometric center of the knee, but rather slightly medial in the joint. And depending on how your bony morphology is, we all have different morphologies of our knees, that point may be more or less medial. When you tear your ACL, and so then the knee translates anterior. When you tear your ACL, that pivot point shifts to a more anterior medial location. And so now when you provide anterior drawer, or when the knee moves anterior, there's a coupled internal rotation, more or less, again, depending on how the bony shape is. So the bony shape is really important. That phenomenon we measure as the pivot shift. And so here's Rolly Jakob, the second president of ISAKOS, way ahead of its time in 1978, when they described the pivot shift and described grading that we still use today, and that was adopted by the IKDC. You probably use that IKDC form as a standard outcome measurement. So grade 1 he described as a glide, grade 2 is a clunk, and grade 3 is a gross pivot shift. Now, of course, you may ask yourself, what actually is a clunk? If you look on the internet and you look on Wikipedia, the clunk is something you can hear, right? It's like something audible. Obviously, you cannot hear the pivot shift. So it's a bit difficult really to say what clunk and gross means. It's really up to your interpretation. And therefore, doing a quantitative analysis, we feel is really warranted. So this video in the middle shows a computer navigation system. You can see on the screen that runs right behind it how the knee moves, and you get complicated curves that will give you basically a translation, rotation, and all this information. Hiro Kurosaka in Kobe and all of his assistants, they've worked on the electromagnetic tracking, which is the image on the left, which is also very elegant. And then Stefano Safanini, the picture on the right, developed a simple accelerometer to also measure the pivot shift. So all of these are sort of available, but really only for research, quite cumbersome. So what we did is something very simple. We basically used markers on the side of the knee. So these 3 markers, the top one is on the lateral epicondyle. The front one on the bottom is on the Gerdy's tubercle. And then the third one is slightly posterior from Gerdy's tubercle. When we do the pivot shift, we basically take a film that goes like this. So this is Freddie on the upper left doing a pivot shift. And then Yoichi Hoshino is on the upper right there. He's basically taking every image from this video. So say your video camera has 100 hertz capability. That means it takes 100 pictures per second, right? So a pivot shift lasts about half a second. So you get 50 images, you stack them like you can see here and measure with a software. It's called ImageJ. It's available on the NIH website. And measure the movement of those two distal markers with respect to the top marker. And then on the bottom left, you get this curve that looks like a complicated computer navigation curve, time on the x-axis, translation on the y-axis. And it's essentially for free. All you need is your smartphone. So that's what we did. We basically imported this type of algorithm into an iPad. We do the pivot shift. The iPad records the pivot shift, and then there's a software program that will analyze exactly those markers. And here's basically the description of it. You can see those two distal markers moving posterior when the knee reduces. And then you get a curve just like this. X-axis is time, Y-axis is translation. And then on the very upper right of the image, you can see 4.79. So that will be the translation that happens doing the pivot shift. In this case, very high grade. If you look at our publications, everything over 3.5 is high grade. And this is very helpful. Of course, you may ask yourself, but how accurate is it if the skin moves, but you're measuring the bone movement? It is accurate, and it's a 3-to-1 ratio. So if you get a number that says 4.7, it's closer to 12 to 15, what the true movement of the bone is, but it's very consistent. So we use this in the operating room. To stay with the ISAKOS theme, we then leveraged in 2011 ISAKOS, who just came out with their research grant for the first time, proposed to them that we would validate these devices and try to come up with a validation for the grading that was proposed in the IKDC, the Glide Clamp Gross. They funded it, and we did a multi-center project with Kobe University, the Rizzoli Institute in Bologna, and Sahlgrenska in Göteborg, Sweden. And we tested 100 patients intraoperatively before surgery, and the image on the upper right is immediately after surgery, and measured their pivot shift, and then measured 2 years outcome. Here is the map with the centers. You can see the investigators there on the right. That's, you know, Hauke Björnsson from Göteborg and Kuroda from Kobe, and then on the bottom is Safanini from Rizzoli. And here's our main publication that came from this. It was published in 2016 in AJSM. And you can see there's translation, we measure with our iPad app, and acceleration, we measure with Safanini's device. And we combine normal and glide, and we combine clunk and grow. So we have basically low grade and high grade. And here are our numbers, 2.0 and 3.8 would be the depicting the difference between low and high grade. And for acceleration, 4.2 and 7.2. So I think there's a bit of a roadmap you can use if you use these devices. So let's talk a bit about outcome. This study was just published this year by one of our fellows, Teresa Diermeyer, using the same data set from this ISAKOS study. We had a total of 107 patients enrolled. They all received an anatomic hamstring tendon. So all of them had hamstrings, single bundle, no lateral surgery, just simply a single bundle ACL. And we found, like most studies show, just under 5% failure rate. We found good outcome. Unfortunately, one thing we wanted to be able to do, we were not able to, is predict outcome based on what the pivot shift is after surgery. We were initially thinking in 2012, if we have a low pivot shift after surgery, that would probably predict a low pivot shift later. We were not able to show that, but I think it's probably a power problem, and a larger study would be needed. So I'm really proud about this publication quite a bit. Here are some outcome studies showing with lateral tenodesis. And you see it's not new. Philippe Neret, also ISAKOS former president, published 24-year outcome with excellent outcome with very little OA. And he published that 10 years ago. And Stefano Safanini published 25-year outcome and Bertrand Sonnery-Coté also published many patients using the ALL reconstruction. So they all have very good outcome too. The big question though is, recently people are talking about really, really high failure rates, 11%, 15%, 17%, 28%, some of the studies. And so the question really is, what is the true failure rate? So Al Getgood, I'm sure you know about this study, published just recently in AJSM. He also obtained an ISACOS grant in 2014, and they looked at 600 patients, 300, they're all hamstrings, 600 hamstrings, 300 with and 300 without lateral tenodesis in young patients, high-grade pivot shift, high-risk sport. And they found that the failure rate at 2 years was 11% without the tenodesis, 4% with the tenodesis. It's a powerful study and very interesting because it would really make you think twice not to use the tenodesis. So let me show you some of the follow-up studies that we did. So when Al and I spoke, I got really interested in this lateral tenodesis because of course the data is quite compelling. So we did 2 years ago here in Pittsburgh, and it's not published yet, so this is fresh, hot off the press. It's been submitted. 20 patients, so a small cohort, but you can see on these images, image A shows one of our fellows running on a treadmill downhill, and they have biplane fluoroscopy with 100 fluoroscopy images per second going through the knee. So we did 20 patients, 10 with tenodesis, 10 without. And then at 6 and 12 months after surgery, we had them run downhill, which measures the anterior translation quite well. They got a CT scan, and we got these 3D models of their knees, and we could then determine 3D kinematics, anterior translation, internal rotation, functional joint space, contact points, all of it in a very, very accurate manner, less than 0.1 degree and 0.1 millimeter accuracy, so very, very accurate. We included patients only with high-grade instability. So focus on the image on the left first, don't look at the 12 months. So this shows anterior translation during downhill running. This is the percent of gait cycle on the x-axis. The yellow bar is a isolated ACL reconstruction, which you see normalized to this black dotted line, is basically like the contralateral knee. So it's a really nice result. If you add the tenodesis in orange, you can see that the knee is significantly more posteriorly translated. The contact point is more posterior. The translation is, if you will, slightly over tightened. So when this data came out at 6 months, I was getting really nervous. This may be too tight. And again, we applied our procedure by all the principles I discussed earlier from the consensus group, where we said we were fixing this not very tight and in neutral rotation and all that stuff. But then the image on the right, you can see this then normalized at 12 months. So the effect of the tenodesis is, if you will, is lost at 12 months. It either stretches out or becomes less relevant. Now the two curves are very close together. And so this is, I think, very interesting data, but may explain why early on, you might have less failures if it's just slightly tighter. Happy to discuss that afterwards. There's a study from Sonnery-Coté and AJSM that claims that with the tenodesis or ALL reconstruction, he protects medial meniscus repair. Very interesting data. I don't understand it, but when we look at our small cohort, we couldn't find that same effect. So putting all this experience from our three-dimensional kinematics study together with stability 1, with such small failure rate, Al Getgood reached out to us about 2 years ago and said to Jay Irgang and I, would you guys want to collaborate on another stability project using patella tendon and quadriceps tendon? And I think this is a super exciting study. We call it Stability 2. We asked the NIH if they're interested in funding this. They said yes. It's going to be a 20-center, multi-center study. It's funded with over $3 million. And it will include 1,200 patients to match the 600 patient cohort instability 1, the quadriceps, patella, and with and without tenodesis. So we just started enrolling. I don't have any data yet. I think 5 patients are enrolled. We basically started 2 weeks ago. So finally, let me talk a little bit about individualized ACL reconstruction, if you bear with me, because obviously individualized or personalized treatment is a hot term these days, whether it's knee arthroplasty, ligament surgery, or any patient care. Any patient deserves and wants personalized care. And I chose this picture because these 2 football players are probably the 2 best, and maybe Ronaldo, some of the best football players on earth. But you see their statue is entirely different. Their playing style, everything couldn't be more different about them. So you better not treat them the same way. To me, what individualized ACL reconstruction means is this, right? If you ask me how many isolated ACLs do you do with nothing else, just the ACL, yeah, like a 30-minute or 20-minute case, I will tell you that's 10, 15% of my practice. Most patients will get a medial meniscus repair and or a lateral posterior root repair, a ramp repair, meniscus transplant, lateral tenodesis, osteotomy. There's something else that goes with it. So to me, that's what individualized means. Individualized also means that you study this patient before surgery. And we almost always get an MRI, and so you can measure how big is the ACL, what's the inclination angle of the ACL, how wide is the notch. This here, 24 millimeters, is huge. It's a huge notch. You can put any graft in there you want. It'll probably be fine. But if you have a 9-millimeter notch and you put a 10-millimeter graft in there, guess what? It's going to impinge 360 degrees. We also measure the quadriceps tendon, how thick it is, the patella tendon, and the patella itself to see what we want to harvest and what would fit best with, if you take the image on the right with the graft choice to the image on the left, so we can match the size of the ACL. That's all work, of course, that Freddie Fu did over the last probably 15 years, and I helped him with some of it. Also, I don't think every graft is for every patient. A hamstring graft will leave you with decreased flexion strength forever, which may be okay for someone like me who is slow and unflexible anyway, but may be very different for a sprinter or a judo person, for example. Quadriceps grafts, for example, will not leave you with a flexion issue, and it will also not leave you with a weaker extension. It'll probably leave you with the same type of weakness any other graft will leave you with after ACL. So what would you do with a sprinter? What do you do with a carpenter that kneels? What do you do with a wrestler that is on his knees all the time? Or judo people that hook their hamstrings all the time? So quadriceps tendon is a really good graft that I will use in those cases, and also is a great graft for the pediatric patient with open physes. Here's Dr. Fu, anatomic ACL reconstruction paradigm. So we respect the footprint anatomy, the insertion site variation, small to big, the tension pattern of the ACL, and really importantly, the morphology of the knee. We created an ACL anatomic checklist published in JBJS, where you can see what is all needed so that you can claim your reconstruction is actually anatomic. And then there's individualized treatment. Sebastian Kopf published this. So this just shows it's a bell curve, how small or big the ACL is from 12 millimeters all the way to 22, the largest that we measured here. And then this is a nice study that was just recently published by one of our fellows, looking at what each of the different grafts will able to provide you as far as a range of graft sizes and how that matches the range of ACL sizes. The image on the top is a patella tendon, which is the smallest graft that you can possibly put in. Although you put a 10-millimeter bone block in it, the tendon itself is only a 4-millimeter strip. The hamstrings is the next bigger graft, and then the quadriceps gives you the widest option because you can obviously take just a superficial layer, or you can take a full thickness graft, and depending how wide you take it, you can go 10, 11, even 12 millimeters. So this is a helpful paper, I think, to describe this. So here's some of my thought processes. Hamstring ACL reconstruction has recently been shown to have a quite high failure rate in young active patients, male and female. The Stability 1 study showed that adding Lateral Tenodesis will decrease that failure rate. Other previous studies had shown similar kinematics between ACL and ACL plus Lat, right? At 12 months, they even out. So really the big question I'm asking myself right now is, in quadriceps and patella tendon ACL, which is what I do probably 90% of the time, what does Lat add to it? I don't have an answer to that, but I'm happy to discuss that with you afterwards. So here's my case summary. This is the case I showed you early on. So this is the 21-year-old high-grade instability, isolated ACL injury, no meniscus tear, no ramp lesion, no root tear, no antilateral injury, no MCL injury. So in this case, what we ended up doing is a BTB ACL reconstruction. You can see I choose a quite posterior point on the femur. So I would say anatomic ACL reconstruction. I don't even mind if the end here, the posterior wall breaks out a bit, because I'm not relying on any particular fixation like interference screws. And then here's, you can see the graft on the lower right here. We try to preserve the stump. If you do, you will avoid impingement of the graft on the roof of the notch. So I think there's a nice ACL. And then I'm sure you're all interested how the lateral tenodesis works. So I just want to show you this video. We added this in this particular case. It affords about a 3 centimeter incision over the lateral epicondyle. Here, this is the posterior IT band, which we leave intact, so not to injure the capillary fibers. Then we harvest a graft that remains attached to Gerdy's tubercle distally, or on the left of your image. We harvest about 6 to 8 centimeters of a strip and about maybe 8 to 10 millimeters wide. This strip then receives a suture just so you can handle it and drive it deep to the LCL. It can be any suture you want. Then you can see here, we already exposed the LCL. My knife is anterior to it, right here, and now posterior to it. So you can use the bovie or the knife, expose the LCL, then take a curved clamp. Here's a Kelly clamp. We go deep to the LCL. I think it's important to have your Lat graft deep to the LCL. And then once it's through, you expose what we call Lemaire's point, which is on the metadiaphyseal flange of the lateral femur. And then I use a staple just like this to fix the graft. The knee is at 60 degrees of flexion, neutral rotation, and the tension on my graft is very low, just like Andrew Amos and Andy Williams described, maybe 20 to 30 newtons, so not very hard at all. I do close the IT band. In some patients, it may get a little bit tight. Early on, for the first 3 months, these patients will have slightly increased pain and slightly weaker quadriceps, but that will even out over time. So here's a follow-up. I just saw this patient recently, so here's full motion. This is 6 months later. You can see the x-ray there. He has still a little bit of a Lahman because he's a quite loose guy. And I would say the pivot shift is maybe a gliding pivot shift, which is symmetric to contralateral side. So in no means will you actually reduce every pivot shift to 0 when you use a lateral tenodesis. So I'm going to wrap this up here. I think we're just about 45 minutes. This is a book that we recently published. Can you grab it from there? So if you're interested in this is a rotatory knee instability. Everybody that has something to say in the literature is involved in this book. We feel that a well-done anatomic ACL reconstruction is key. You address concomitant pathology, as I mentioned, meniscus, roots, etc. We consider the bone, especially the slope. I didn't talk much about it, but we consider that in a complex revision case. We also consider the tenodesis maybe in a select group of patients. Here's the book. I'm happy to be able to present that to you. And here's just a vision I'm going to show you real quick. This is a funny slide. Many of you probably know Dr. Fu's talks. About 20 years ago, when I came to Pittsburgh, I was helping him a lot with his presentations, and at the time we made a talk, and we said, what is our vision for 2020? Now that it is 2020, and then our vision was we will use computer navigation, gene therapy, and all this. Some of it came true, some of it didn't. I made a 2040 slide just for old times' sakes. So you have an ACL injury. I think in the future we will do much more 3D planning. I think there will be virtual reality. It's already there. I know Pune, for example, is way ahead of everyone else. With that, we use 3D arthroscopy. And then on the other side, what we use is stem cells, I think, much more. There will be nanotechnology where the stem cells can be put into a graft. We 3D print the ACL, and then we have the perfect outcome. So with that, I thank you very much for the invitation, and I will take any questions. I will try to. Thanks.
Great, thank you very much. That was an excellent overview on quite an extensive topic, and congratulations to you and the Pittsburgh team for the work over the years to help us better understand this problem. So just to kind of get your thoughts on a few things. So we'll start with, we've got around 15 minutes and you really finished on time. I'd just like to apologize to Neha. I think she tried to log in earlier, but we couldn't recognize that she's the Zoom login, so we couldn't accept her as host, but I realized subsequently. So she's doing a lot of background work, so thanks very much to her too, for
yes,
organizing.
Right here.
Thank you.
Thank you. Thanks. So let's talk about the anteromedial rotatory instability. Now, the commonest situation we face is an ACL with an MCL. Now, if I refer to a recent publication from the Swedish registry, what they have noted is that the failure rate of a primary ACL in patients with an associated MCL is higher when the MCL injury has been treated non-operatively versus the cases where they were treated operatively. And this was published in the ESCA journal. And I'm sure you've come across this paper. It was a large number of studies. So what are your thoughts about, because historically we used to say give priority to the MCL to heal and then go ahead sometime later or some weeks later and do the ACL. Has that thought process changed, and what are your views on this?
Yeah, I think it is changing. I think we are getting more aggressive. Let me go back a little bit. So the Swedish registry obviously is powerful because they have way more than 25,000 patients in this registry. So the power is in the number. The weakness of any registry obviously is you don't have exact data for every patient. The controversy remains, of course. When do you treat the MCL? What grade? And also what best timing to use? I want to tell you real brief about the STAR trial, a study that we started in Pittsburgh about 2 years ago. STAR stands for Surgical Timing and Rehabilitation for Multi-Ligament Knee Injuries. So in our study, we're trying to find out if early surgery or delayed surgery is helpful for the patient, specifically with outcome going back to work at a faster rate, and of course also complications such as stiffness. So if, of course, you want to hear from me specifically, what do I do with sort of the grade 2, 3 type of MCL? I will take, like I showed earlier, I will take a C-arm in the operating room, and under anesthesia, I will measure. And if I have more than 2 to 3 millimeters of side-to-side difference in medial joint opening, especially when it's an extension, then I consider a sort of medial repair. I'm not very keen on these reconstructions that will early on put grafts on the medial side. I think if you get there acutely, you can repair it really well. I use anchors, I use AO screws, and I will fix that because I believe the Swedish registry has a very good point there, that the outcome is better if you treat this. Now be very careful with stiffness. If you do too much, the MCL, the medial side will haunt you. It will get stiff as you've never seen stiffness before, so be careful.
Yeah, great. Now, so do you do the stress views after your ACL reconstruction to assess the residual before?
Before.
Okay, so you plan to do that beforehand.
Yes, exactly.
Now while we're at the registry, again, in this year there's been a publication from Martin Lind, again from the registry, saying that the quadriceps tendon, if whenever used in conjunction with the primary ACL, has shown a higher failure rate compared to patella tendon and hamstrings. What are your
Yes, so let me tell you about this. So one of the last meetings we had before COVID-19 started hitting the world was the ACL study group in January in Austria. And Martin was there and explained his paper and did an analysis afterwards. So for those of you who don't know the paper so well, it's the Danish registry, and they looked at hamstring versus patella tendon versus quadriceps tendon failures. They have multiple thousand hamstrings, multiple thousand patella tendons, and 400 quadriceps. So that's the first weakness. But Martin explained, and I'm just basically paraphrasing him, that initially they thought that may be a learning curve. They did not find that. They found there was in a few centers, okay? It was a few of their centers, and all the other centers were normal. And you also should know, when we're talking failure rate, yes, it's statistically significant. But if you look at the actual numbers, they had a 1.5% failure rate or 2% failure rate for hamstring and patella, and a 4% failure rate for quadriceps. So it's still a very, very low failure rate, would you say? So I am not concerned about that study one bit.
So you tend to use quads tendon in your regularly?
Yes, very much,
and,
very much.
And the
and
four
I
layers?
personally have a smaller failure rate. I don't have a high failure rate with this, but I showed you in my one outcome study, I would say around 5% is where our failure rate is.
And one of the reasons cited by that study was that because if you take the 4 layers of the quadriceps tendon, the collagen in the middle layer is actually in a not perpendicular or along the long axis. So that could be the reason for elongation. Do you take the entire 4 layers, or what is your approach?
No, I do partial thickness. That's a great question. I do partial thickness, and if you do that and also avoid going too proximal and avoid harvesting any of the rectus muscle fibers, the patient will recover a little bit faster.
But you take the bone plug on the patella side? Or
no, not usually. I use soft tissue only, and I will use the bone block in patients that are, for example, very short, where I need more length. And I will use it, of course, when I do PCL and revisions and such.
Great. Now, talking about the high-grade pivots, now you did mention that, you know, an associated meniscal pathology can also contribute. So when you encounter such during your surgery, so you've done an ACL, you've also repaired the meniscus, do you then decide, suppose if it's one of the high-risk groups, say a young patient, would you just blindly go ahead and do an LET, or would you then assess the pivot and then take a call?
Great, that's a great question. So Charlie Brown has this nice little study where he showed that after the fixation of his lateral meniscus root, he reduced the pivot shift by 1 grade. And I want you to be on the lookout for a paper that we're publishing right now in AJSM. It will come out here in the next few months by Andy Sheehan, S-H-E-E-A-N, and myself, where we did exactly what Charlie Brown did, but we used our pivot app. And we measured this, and I have to tell you, unfortunately, every knee is different. So I could not confirm what Charlie showed. I have some patients where you fix the meniscus or you do a tenodesis and you reduce the pivot shift by a grade, but that's not true for every patient. So to answer your question, I make my decision pre-operatively. And currently we're using the stability study, and we develop criteria. I'll develop criteria that we adopted, which are, if the patient is under 25, we might consider this. We need 2 of these following factors: young patient playing in a high risk sport, being hyperlax, and or having a high grade pivot shift. So 2 out of these 4 factors. And I will measure the pivot shift pre-operatively under anesthesia with my app. And if the numbers are bigger than 3.5 side-to-side difference, which is what I showed in that publication, I will consider it, but I make my mind up before surgery.
Great. So I agree. And, you know, the stability one study clearly showed that it reduces the failure rate to around 4%. But one of the concerns with an LET is stiffness. Now, obviously, you've clearly highlighted that you fix it in the right degree of flexion. It is better compared to an ALL where you would do it in extension. So now, what are your, on your follow-ups? Do you see stiffness as a concern when you do LETs?
No.
Okay.
No, I don't. I don't see stiffness as a problem. As you know, any ACL has the risk of losing some extension, right? But that is independent of the LET.
Great. And I think the other thing which you showed in your technique is that you fix it with a staple, because tunnel coalition with the ACL can also be a little, but so
Yeah.
certainly using a staple eliminates that sort of a problem. No,
yes, and the staple is cheap. You know, you don't need a big anchor for that. You can obviously use anything you want there, but I feel the staple is a good fixation. And if you bury the staple nice and deep, the patient usually does not have problems with hardware irritation.
Now, does your rehab vary when you add an LET versus just a isolated ACL?
Yes, it also varies when I use quadriceps versus, for example, patella tendon. And it varies in the sense that early on, they're a little bit more painful, a little more inhibited with the quadriceps. So we're doing some short arc quadriceps and so forth. If you want to, I can share my rehab protocol and send it to you.
Yeah, that'll be perfect, because I think that makes a difference in terms of the survivorship as well. So no, that's great. Now, another paper which has come up in the AGSM about, high volume surgeons trying to locate the center point on the femoral tunnel. And you did mention in your concluding slide that, a well done anatomic ACL is really the reason for survivorship. Now, with that paper, it's clearly highlighted that, 121 high volume surgeons could not locate the point accurately unless you did the Bernal-Hertel grid on fluoroscopy. Do you normally use that, or how do you go about doing your femoral entry point?
Yes, I'm going to show you something real quick. I actually was trained by Hertel, and here he is. So I need to show you this, of course.
Great.
This is Hertel, this is myself, this is Freddie.
Amazing.
So I have to share that real quick, because Hertel and Bernard are two wonderful people that are dear friends of mine and mentors. And I use this grid. I do this. Now, they described it so that you could use it intraoperatively. You can put a pin there and then measure with the fluoro. I don't really do that intraoperatively. But if you do it a few times, either in the lab or intraoperatively, then you get a sense where it is. And then you can imprint this in your memory. And going forward, you know where to go. So I think it is key that you, in one way or another, whether it's a laboratory study or whether it's live, that you try to find out where your tunnel actually is. If you never look, you will never know. And I will admit to you freely that there are cases where I misplace my tunnel slightly, and I only find out later when the x-ray comes, or say the patient fails, and now you look at a 3D CT scan and you will realize it. Study it again and again so that you learn, and then you can get better.
Sure. Now, in one of your slides, you showed that you go a little bit higher and, towards the posterior part. Now, is that what you do? Because the ideal concept, I don't know whether you've come across that. They seem to suggest, do you follow that or do you go somewhere in between?
No, I don't know. So the concept basically is when you go into the notch, you see the stump of the old ACL. So just put it right in the middle. So I know that the ideal concept talks about, direct fibers and indirect fibers. Look, every ACL is different. Every ACL, if it's a young patient, has much more direct fibers. If it's an old specimen that's studied in the laboratory that is 75 years old, well, when are you ever doing an ACL on such an old patient, right? So I'm telling you, every ACL is different, and just go right in the middle of the anatomy.
Recently, the use of internal brace has been advocated. What are your thoughts? What do you see it to be like?
I'm going to paraphrase Einar Eriksson, the godfather of ESCA and KSSTA. He said at one of the ACL study groups 3 years ago, look, we used Leeds KO and artificial and Gore-Tex graft in the 90s. They all failed. And he said, quote, it's like putting a shoelace. Why would this work? So I think it has some role maybe in the extra-articular setting somewhere. If you so want to put a big suture there, then do that. But in my practice, if I want a structural support, I will choose a tendon graft rather than a suture.
Great. Another dilemma which we face is in patients who need a slope correction, especially in the revision situation. Now, we always measure the medial tibial slope, but actually the pivot happens on the lateral side. So what are your thoughts? Should we also be measuring and looking more closely on the lateral tibial slope vis-a-vis the medial?
Yeah, that's a good point. I mean, unless you have an MRI or some sort of three-dimensional imaging, you will not really be able to do medial versus lateral slope so accurately. I prefer using the X-ray to measure my slope, and I basically take the average there. The MRI will underestimate the true slope.
Great. And, obviously we are doing our ACLs well, we are adding LET, so we are getting better in terms of the reduced failure rate. But as Julian Feller and group have published, and they've highlighted that there is another element which is not in our control. What do you see, I mean, in terms of the, the return to sports, even if we improve our surgical techniques and reduce our failures,
right,
is our percentage of return to sports going to get better?
Yes. So look, for return to sport, the problem is that all the things that we measure to get the patient safely back are all surrogate, like indirect factors. We measure the strength of the quadriceps. We measure the ability to do a hop test. We measure endurance, biodex, all these things. But none of these measurements really tell you what the graft looks like. So if you get an MRI as follow-up and you have serial 3 months, 6 months, 9 months, 12 months follow-up, and of course, ideally actual biopsies, which are impractical, then you will see that the ACL graft heals over time. And even at 1 year, will still heal. So unless we convince our athletes, especially the young ones, right? Professional athletes have contracts attached to them. They have to move in a certain pace. But the young students, the young scholars from the schools, unless we convince them to wait longer, 9 months, 12 months at least, we will continue to have high failure rates. Great. That should be your mission. Save the kids.
Fantastic. So one last, this last minute, yeah. Ranjit, do you have any questions?
Yeah. Dr. Volker, a very good presentation. Now you have told that you are not preferring this MCL reconstruction or augmentation because of apprehension of the stiffness. But suppose you have a mid-substance MCL tear along with ACL tear. In those cases, how confident you are on your repair, or in those cases you augment with a tendon or some kind of internal bracing?
If it's a true mid-substance rupture, which I see not as often, then I would consider putting a graft there. And I'm quite quick using allograft rather than semi-T. If you use a medial soft tissue graft, I think you're robbing Peter to pay Paul. If you have an MCL injury and you take a hamstring graft, you're taking one of the stabilizers away. So I would rather use an allograft. Most often, though, I see femoral or tibial avulsions, and they're very amenable to repair.
Yeah, similarly on the posterolateral side, in case of acute PLC injury, how often you go for acute PLC repair, and how confident you are on the acute PLC repair even if the tissue quality is good, or routinely you augment or reconstruct in case of acute PLC injury?
Yes, I will repair it, but my default is a graft on the lateral side. And I think there are good papers from Rob Laprade and Bruce Levy that showed that they just stretch out too early. I have few patients that only have a repair. I go to a graft quite quickly.
Okay. And sometimes along with the ACL tear, if in case it is associated with both anterolateral and posterolateral instability, and then how reliable is the pivot shift test? Because in both the cases and along with ramp and the root tear also, we get the similar kind of pivot shift test. So what is the clinical case in those scenarios?
You're right. The pivot shift, you cannot rely so much on it. When you lose too many restraints, then you will not feel that clunk. But I'm not feeling the clunk. I'm using quantitative measurements. So that will not change depending on what soft tissues are gone. The movement will still be there. You just won't feel it as much. So using the quantitative device is helpful. And using stress fluoroscopy with varus and valgus is something I use there. Okay, I have to run now.
Sure. No
Yes.
problem. On personally and on behalf of the Indian Arthroscopy Society, we are really grateful for your presence. You gave an excellent overview
Yes.
on the topic, and also the Q&A was wonderful. So we look forward to connecting with you in person at some point.
Thank you.
Thanks
It was
very
my
much for your
pleasure.
time.
Thank you.
And thank you to
Thank
Thank
you.
you
Neha
for
as
having
well.
me.
Thanks a lot.
Thank you.
Pleasure. Bye. Bye-bye.
Bye. Thank you.
Ranjit, are we going to announce the next? You
Yeah,
have any?
Sandeep is there. Hello, Sandeep. So I think there are no recent announcement for any other program.
Great.
We'll let the
conclude this
delegates know.
webinar.
Yeah, we can conclude.
Thanks, Ranjit, and thank you, everyone. Bye for now.
Thank you. Thank you.